Dr. Paul Brown received his doctorate in economics from the University of Wisconsin and is currently a professor of health economics and public health at UC Merced. He has many research interests, including health services research and analyzing interventions aimed at improving health for vulnerable populations. More recently, his research has focused on the particular health challenges in rural and medically underserved regions. And today he will be talking to us about Medi-Cal and what it means to be medically underserved in the US and California in particular. So thank you so much for joining us today, Dr. Brown, and the floor is yours.
All right, well, thank you. There's a couple people from UC Merced who've kind of joined in. So Teresa, you want to introduce yourself?
Sorry. Sure. Hang on. I guess
Okay.
Hi. I'm Teresa Spezzano. I am finishing up my my PhD under Professor Brown, and my research is mostly in behavioral economics and basically using what do I do? Right now I'm feel like I've been working on COVID forever. So that's pretty much what I'm doing now.
Yeah. Angela?
Oh, hi, my name is Angela Pereira. I'm an international student from Colombia. I'm doing a PhD in Colombia, but I'm here right now doing a research internship under Professor Brown advisory, and my thesis or my research project is about alcohol and cannabis consumption in young adults, and I'm trying to learning with Professor Brown how to do DC surveys and how use that information to formulate public policy for substance use in my country.
Adriana?
Hello. Hi, everyone. Well, I'm physician by training, so yeah, you're in the WhatsApp. But got interested in health economics and how to improve the way we use resources, and that's when I met Dr. Brown. And right now I'm researching how to determine access and preferences in rural areas and how those affect the way people make decisions and how we can improve their access to healthcare. So welcome.
And Nimrod?
Hello everyone. Just wait a second. Hello everyone. My name is Nimrod Sandhu, and like Adriana, I'm also a physician by training. And I've been with Dr. Brown for the past 3 years, although this is the beginning of the 3rd year of my PhD. And I look at healthcare access and healthcare utilization. And my research focuses on how to improve healthcare access and utilization, as well as how to improve health system integration for farm workers in Central Valley. I've been lucky enough to work with Dr. Brown on the UC Merced Farm Worker Health Study, and we've been working on that for the past 2 years. And now we're moving on to a project looking at how we can develop more effective policies for improving healthcare access through health insurance for farm workers in California. It's really nice to meet all of you.
Well, thank you. Did I miss anyone from UC Merced? I think that's everyone. So I am a health economist. So my background is that I grew up in one of the vast suburbs of Los Angeles and went to UCSB as an undergraduate to study. Well, I went to the study to become a psychologist, but I quickly realized that was not, that I didn't have the grades for it. No, that's not right. Yeah, that is right. So I went, and I also did economics too. So then I did a PhD in economics at Wisconsin, and I did it mostly in just behavioral economics. I didn't do anything in health. And then I got a job in back in Boston. So I worked in Boston for a while and Then we lived in Philadelphia, and my wife's she's a real psychologist. So she's also an academic, and she got a job offer to move down to New Zealand. So we went down to New Zealand, and I went down there, on a sabbatical, but thinking is that I would just hang out. And after about a month of me hanging out, she said, you should go get a job. So I looked in the papers, and the only thing for an economist was that there was an opening for a health economist with the Ministry of Health, the New Zealand Ministry of Health. And New Zealand's healthcare system is kind of like the English healthcare system. So, the government, kind of runs the hospitals and employs the surgeons and, specialists, and the primary care doctors are all kind of independent, but they all get subsidized by the government. So it's a national health system. So I worked for the Ministry of Health. And then after that, I got a job at the University of Auckland in their medical school. And so I started, teaching in the Masters of Public Health program. And I also then used to teach medical students as well. I quickly learned that most medical students don't really care about health economics. I learned that if you go in there, that especially during the first and second years, people are just kind of focused on what type of clinical skills they need. And things like health economics is somewhere down the road. On the other hand, I used to go talk to the residents, and the residents, that's all they wanted to talk about was health economics, because then, as residents, they're kind of out there and they're trying to figure out why it is that, they have to work long hours and why they get paid low and all these different things. So suddenly they were much more interested in health and economics by the time that they got to be residents. And then I came to UC Merced in 2011, and I've been there ever since. My area, as Elizabeth said, is what's called health services research. There are 5 branches to public health. There's epidemiology, biostatistics, environmental health, health promotion, and health services research. And so health services research tends to deal with the health service. So that's what I teach on. I teach on like how about introduction to the U.S. healthcare service. If you want to see all my lectures on it, they're on YouTube, so I can send you a link. But then I also teach on other things as too. Like I teach about health services research, about health economics, and things like that. So as I understand it, Elizabeth, kind of had said that you want to, I can come and talk about health disparities in the health system. Can I start by saying, how much exposure have you had so far to kind of how the health system works? For example, like how many people are uninsured? What percentage of people are uninsured in the United States? Have you gone through things like that? In chat, give me a yes or no in chat. Virtually nothing. Okay. All right. Well, I'll show you then. A good place to find all this type of information is the Kaiser Foundation. So if you go to the Kaiser Foundation, they have lots of things in terms of how the health system works. So here's what the numbers look like from 2019 about the number of insured in the United States. So about half the people have employer insurance. About 20% have Medicaid. And again, Medicaid, that's for, there are 2 big state-run, government-run programs, Medicare, which is for people over 65, and Medicaid, which is for, it's run through the states. And it's for, well, there's lots of different criteria about who gets Medicaid. So California has a fairly, like down here, you'll see California has a very liberal type of expansive type of Medicaid program. It's called Medi-Cal here. So you get about 25% of people in California are in Medi-Cal. I think the numbers in Merced County are 50%, I think, are in Medi-Cal. So if you figure that 50% are in Medi-Cal, and in California, somewhere about, 15% of people, in Merced County, about 15% of the people are Medicare. So you're talking in Merced County, about 65% of the people are on some type of government health insurance. And that doesn't count kind of military and other types of things, and people who work for state governments and things like that. And then the unemployment rate, the uninsured rate is about 9%. Now, has that uninsured rate gone down or up over time? So what do you think? Give me has the uninsured rate in the last 10 years gone down or up? Take a guess and type in up, down. it has come down drastically. So the uninsured rate used to be like, late 2000s. Uninsured rate was kind of talked about being between 17 and 30% of the people. So the reason why it was a big range is because there's about 17% of people who didn't have any insurance at all. And then there's about another, 13 to 14% who had what was called, they were called underinsured. But what that basically meant is they had these plans that might have a deductible of like $10,000. And then, so it means they have to pay the first $10,000. And then they'd have a co-payment of, 40%. That means they have to pay 40% of everything after that. And then there's usually a cap, like at $1 million. So it was insurance, but it was so, it was so kind of bad insurance that, people, like, for example, if you have a $10,000 deductible, you're not going to do very much in prevention. You're not going to be going out and paying for yourself to get, colonoscopies or things like that. So they were called kind of underinsured. And so that means about a third of the people. So that means we went from a third of the people without much insurance down to about 9%. What caused the change? Yeah, the ACA, Affordable Care Act. So the Affordable Care Act is what caused the change. Is that it was, the Affordable Care Act was all about trying to get people to get health insurance, and it worked, right? Turns out that, if you make health insurance more affordable for people, and that you standardize what the policies look like, which is, what the Covered California kind of exchange is all about, then, people buy health insurance. Did Trump, did things change much under Trump? Did the uninsured rate go up or down under Trump? What do you think? Did the uninsured rate go up or down under President Trump? Yeah, relatively stable. And surprisingly, because, especially in the early days, he tried a lot of things to kill the Affordable Care Act. But it turned out that it didn't really change that much. And partly because one of the big things the Affordable Care Act is expand Medicaid. And so that never changed. And what he tried to do is basically get rid of the penalties for not having insurance. But it turned out that people like to have insurance. And so, if you give people the option to have insurance, they typically buy insurance. So it didn't really change all that much under Trump, despite his best efforts. So I would say, note this, Kaiser Foundation website, because it is a good place to go and to find different types of information. Okay. Before I jump into health disparities, any other questions about the healthcare system in general, like how things work? And you can say it out loud if you want to. You don't have to type it in. All right, not seeing anything. We'll just move on. Okay, health disparities. So can you give me a kind of a brief summary about what you've talked about so far under health disparities, so I don't repeat things? Like, what kind of things have you talked about under health disparities so far? Elizabeth, what kind of things have you talked about under health disparities?
We've talked a lot about like social determinants of health and more structural components.
Like, what do you mean by structural components?
Like a little bit about policy, but very broad, nothing very specific.
Okay. All right. Well, I'm going to focus on health disparities as it relates to the healthcare system. And I have to say also, this is just my kind of think of this as my own stylized view of things. That you could get another person in here and they might give a very different take of all this. So consider this my stylized view. And stop me if you have any questions along the way. All right, first off, so what are health disparities? Well, what health disparities typically means are avoidable differences between groups where the differences can be by gender or race or ethnicity or or anything basically, any type of categorization can be, you look for differences between those groups. And there's a basic assumption is that the differences between the groups in terms of, could be incidence, could be prevalence, could be mortality, could be burden of disease, whatever it is, right? That could be the number of how people get access to healthcare, could be, what kind of with the quality of healthcare they get. Any of these things kind of goes into the category of health disparities. The key, though, to it is that it's somewhat avoidable. It's seen as avoidable. For example, if you look at, someone who's, if you look at my mother who's 97 now, 97, and you look at her health condition, and you look at the health condition of, of Adriana, is that you would say, my mother has worse health than Adriana. And so would you say, ooh, there's health disparities there? Not necessarily, because my mother is 98 years old or 97 years old. So therefore, she's going to have more health conditions than Adriana's going to have. So therefore, it is sort of seen as that it's got to be something that is somewhat preventable, avoidable, that there's something that went wrong that makes that explains the health disparities. Now, health disparities was the term that was used, it was the term that was used up until probably about maybe 10 years ago, when the language started to change and that they started to talk about health equity. So health equity, here's the CDC's definition, is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So what's the difference then between health disparities and health equity? What do you think? What do you see as the difference between health disparities and health equity? Anyone want to give it a shot? Well, I think the way I look at it is that health equity kind of implies, health disparities is a descriptive term, right? It sort of says there are these differences between people and that the differences are avoidable. Health equity, though, starts to bring in the idea of obligation or right. That is that when they talk about health equity, then the idea is that not only are there differences, but the differences have some type of I won't say legal, but sort of say ethical type of component to it. So that, you might look at health disparities and say, yep, definitely health disparities between people who live in the San Joaquin Valley and those who live in, Marin County, definitely are. But you might not say that there is any type of obligation that society has to do anything about it, right? On the other hand, when you talk about health equity, there's this implicit assumption that people, that any type of differences you see like that is somehow unequitable, meaning is that it's, there's some type of fairness idea that comes into it. Okay, so when we talk about from a health system standpoint, then if you talk about health disparities or health equity, and I'll use them interchangeably just because I'm old, but you can think of them as that, the main they're both basically describing the same thing. They're just sort of describing the different aspects of it. So there are three kind of dimensions to health equity then. So one is equal opportunity to access care. The other one is equitable access or utilization of care. And the third one is equal outcomes. So to distinguish these things then is that, well, partly this is not just kind of an arbitrary type of idea. So in health for doctors, which do you think that doctors like to be, if you're going to go through and judge a doctor based upon the how good they're doing in health equity? So let's say if you went and you started working for a healthcare federally qualified health clinic and you're dealing with patients and they come through and they say, okay, so, we're going to now judge you based on health equity. So which of these would you like to be judged by? Equal opportunity, equal utilization, or equal outcomes? And what that means is that, you got a group of patients over here who, have health conditions. And so, you're responsible for them. And so if their health, and so either you're going to be judged by saying, do you give them the same opportunity to access healthcare? or you're going to be judged by saying, do these people actually use healthcare? Or you're going to be judged by saying, do these people have the same outcomes? What do you think most doctors would like to be evaluated on? Opportunity, utilization, or outcomes? Outcomes, utilization? So let's take outcomes. Suppose that you have a patient with diabetes who comes in, and that, so you have two patients with diabetes, right? One of them has good health insurance, comes from a very stable environment, has, good transportation, lives right downtown so they can get to a pharmacy easy. The other one lives in a rural area, no transportation, doesn't have very much income. Are those people going to have the same kind of health outcomes? Will they have the same health outcomes? What do you think? Yes or no? I mean, I'll put it this way. Should you be judged based upon whether they have the same health outcomes? So we think, yes, I should be judged that way, or no? No, why not? Why shouldn't you be judged that way? Because that's what judging on health outcomes means, is I'm going to look at these two patients, and if they don't have the same health outcomes, then I'm going to say, ooh, you're not providing good care. So what's wrong with that? I guess outcomes are based on different factors, which may be out of the doctor's control. Yeah, that's exactly right. Because, there's lots of reasons why it is that someone might not, might not go through there are lots of barriers that the person can face. And the question becomes kind of like, well, as a doctor, how far do you draw the kind of the circle about what your level of responsibility is? So for example, if you really care about health outcomes, then you might sit there and think, all right, well, I'm going to make sure that this person gets transportation to come to the clinic. And if the person can't pay their electricity bill, I'm going to go out there and make sure their electricity bill gets paid so that they can, use the equipment. And I'm going to make, so you would take responsibility for all of those things. On the other hand, if you just focus on opportunity, then what you can say is look, everyone has the same, I make appointments open to everyone, is that, in that all you have to do is just call up and make an appointment, and I'll see you. I make no distinction based upon who gets, who's going to be able to see me based upon any type of health condition. So that's why, opportunity is the least restrictive for healthcare providers to be judged by. Outcomes is the most restrictive, and utilization is someplace in the middle. For example, if you have a patient that speaks Ilocano, right, and that they and so they don't come and see you because you don't speak that language. That's the difference. You're giving them the opportunity, but you're not good. But the utilization is not going to be the same because they're actually not going to use you. So if you're going to be judged by utilization, that means that you're going to now, trying to look at, okay, well, what type of barriers do they have to actually coming in that I can help solve? And if it's language, then you might think, okay, we'll provide translation services. If it's cost, then you might say, okay, we'll make it free to them, whatever it's going to be. But now you're trying to kind of deal with some of the issues that would prevent them from getting in the door. So this is not just kind of an arbitrary distinction then about how you want to look at health equities. Is that when they start going through and they do some of these things like pay for performance, where they pay clinics and pay doctors based upon what their outcomes are, you can see the tension, right? If they pay upon health outcomes, then what's that going to do for doctors? Well, it says better take patients who are going to be high up on the income scale so that they're more likely to be able to adhere to your treatments. That's called cream skimming. And at the same time, if they pay based upon just process stuff, like how much do you like send a letter to people to say it's time for your diabetes checkup, things like that, then you're sort of talking more about opportunity at the other end of the scale. So in general, healthcare providers like to be judged based upon the opportunity rather than health outcomes. Okay. Questions about that? I think physicians pride themselves on outcomes that they utilize, that for those that utilize healthcare. Opportunity is harder to show. It's a great point, because when you look at who it is that who it is that they report statistics for, most healthcare providers are fairly silent, right? So they have their patients and they report statistics for their patients. What they're not reporting statistics for are the other people who they're not treating, or the people who are, have fallen through the cracks. And it's because, it's a difference between when you try to do reporting based upon, from a provider standpoint about who I see, versus from a population standpoint. So from a population standpoint, you might come through and say, well, we're going to look at everyone in the system, not just those who are in this healthcare setting, but also the people who aren't. And that's what we're going to report on. But everyone who does any type of work like this wants to be, they want to be able to be judged on what they can control. And if they can't control these other people who are not going to come in, then shouldn't be judged on it. Okay. So from my standpoint, then, you can think then about distinguishing between determinants of health, determinants of getting access to care, and determinants of getting, adequate treatment, getting good treatment. So, determinants of health, then, those are going to be the things that those are your socioeconomic determinants. So here's kind of a list of different types of socioeconomic determinants of health. Let me make this a little bit smaller. Go through. And the idea is that, all these things kind of lead into health status. And so, for each of these different type of areas is that there is different types of barriers that people face. And there's also kind of racism and discrimination that goes across everything. So that even people in this, in the same situation, same kind of objective situation, can have different types of outcomes in terms of their health status, just based upon sort of systematic racism, things like that, which we'll talk about. For access to care, this is kind of shows that people of color face, always have faced, disparities. The Affordable Care Act kind of got things a little bit better, right? So these are uninsured rates, but it's still pretty high, and there's still the gradient across ethnicities. In terms of health outcomes, well, there's, I'll refer you to the CDC has put out one of their reports that basically just focus on disparities in health outcomes, and it's a huge report, and they list a whole bunch of things, and the basic message that comes out of it is that people of color, when you look at COVID, had higher rates of infections, hospitalizations, and deaths. All right, so let's talk about COVID. We'll take this as an example to sort of talk about, all right, so how does, from the way I view things, how does kind of these type of health disparities kind of play out? Well, I think the one thing to do is just to break up COVID into two different things: risk factors associated with getting COVID, and then the other one is risk factors associated with bad outcomes from COVID. So if you think about what were, especially in the early days, what were the risk factors associated with getting COVID? Is that, working in essential industries, not wearing masks, and not social distancing. What were the risk factors associated with bad outcomes? Well, age, chronic conditions, and not getting adequate treatment. So if you want to think about, all right, so how does this work then? Is that, you have risk factors here, and that kind of influences then your probability of getting COVID. And then once you get COVID, you can have bad outcomes or good outcomes. So if you take it out a little bit farther, you think, all right, so what are the things that's kind of impact this? So one is kind of the work, the workplace, in terms of like just within your workplace, what is the environment like in your workplace? Another one is the business in terms of how much they could go through and that they could limit COVID, limit the exposure. And then the third is kind of what the public health system is doing in general to limit the spread. So you had kind of three different factors kind of working here. So if you think about, the difference between these two is that, like if you think of someone in a meat packing plant, right? someone in a meat packing plant, they're in an environment where they're going to be working closely together in an environment that turned out to be very, very prone to passing through COVID. On the other hand, if you think about academics, they told us academics, okay, don't come in the office, and all academics went, woohoo. So we just all Zoom from home. So therefore we were in an industry that we could go through and that we could, basically limit. And then in terms of the public health system is that, if you look at the differences between counties, between regions, some counties did really well in terms of contact tracing, in terms of, limiting the spread, getting, enforcing mask mandates, et cetera. Some places did really, really poorly. Then once you get COVID, then is that, okay, you've got your risk factors, age, morbidities, et cetera. You also then have access to the healthcare system, so that the access to the healthcare system kind of determines not, how much treatment you get, or, what type of treatment, how good, and that influences then your good and bad outcomes. So this is kind of the way that I sort of think about, within the social determinants of COVID, how that links into some type of health outcomes. All right, so the question is, let's start with the first one. What's the association between infection rates and then, the ethnicity, socioeconomic status, however we want to measure kind of health disparities? Well, people of low socioeconomic status and people of color tended to work in higher risk jobs. They worked in places that were less likely to socially to put in protections to help them from getting infected, more likely to live in crowded homes, more likely to shop in stores, more likely to live in counties where there's less public health infrastructure, and so where there was less like contact tracing and everything else, more likely to be reluctant to be traced by government agencies for contact tracing. So it kind of goes on. Were there differences in behaviors between kind of, people of high and low socioeconomic status? Didn't really appear to be. I mean, when they looked at kind of willingness to wear masks and things like that, and the importance of wearing masks, et cetera, there wasn't, you didn't see those sort of big differences between groups, at least, especially not in the early days. You saw differences later on that based on more political views, but not necessarily based on socioeconomic status. So that means that if you look at and you sort of say, all right, so what are the what are the determinants then that make it so there's a, people of low socioeconomic status or people of color, or however you're going to define, what makes them more likely to get COVID? It's all these different type of determinants. Okay. Then if you say, all right, so what's the association between socioeconomic status and health outcomes? Well, first off is that more likely to have comorbidities, less likely to have access to healthcare, particularly ICUs and specialized treatments and things. So it meant that for those who got COVID is that they had higher risk factors, poorer access to healthcare, and poorer access to treatment. So, what that meant then is that you ended up with a pretty big socioeconomic gradient in terms of exposure and in terms of health outcomes, because of the way that all the factors that led in to being able to access good healthcare system and good treatment. So if you look and you think, well, all right, so if we were to go through and to look at take a step back and say, so how did socioeconomic factors explain health inequalities in COVID? Gender, not a big difference. I mean, there was some difference in terms of males being more likely to work in essential jobs, but not, there weren't huge differences. Sexual orientation, another way we can measure socioeconomic, didn't seem to be any big difference. Disability, another measure of health disparities, big differences there, especially in severity of illness and in life expectancy. You saw big differences in terms of education and income, also big difference in terms of racial and geographical location, and also big differences in race and ethnicity. So the conclusion from COVID was that, there were a lot of factors then that kind of led to this socioeconomic gradient that we see that led to health disparities. All right, so questions before I go on? All right. So now let's focus on income. So why, income is one of the common ways that we talk about in terms of health disparities. We say, there's health disparities by income. Well, income is a proxy for a lot of things, right? Income, one is the proxy for stress. So one of the things that they found early on, like in the Whitehall study and things, was that there was a big socioeconomic gradient in terms of income. And it was really linked to socioeconomic gradient in terms of job status. And the reason seemed to be is that people at the lower end of the jobs scale tend to be under more stress than people at the higher end. Also, income lets you live in safer communities. It gives you more food security, better access to healthcare, better access to healthcare providers. So like in our region here in Merced, we don't have very good access to healthcare providers. So if you look then, so here's the map of California. This is the gross adjusted income, is that you can kind of see, this is on the left there is the population map. So, we have LA, you have the Bay Area, then this is basically the 99 corridor that goes to Sacramento. Those are your primary, population centers. And then this is what the income looks like. So income in, a lot of the Bay Area is on the higher end. And then income in, in sort of the Central Valley here tends to be kind of on the lower end down there. And then also way up here north tends to be on the lower end. So you'll note that urban and coastal areas tend to have high incomes, right? That means they tend to have high rates of private insurance and they tend to have more doctors. So income leads to more private insurance. More private insurance leads to more doctors. And the two are linked because private insurance, so if you think about how people get insurance, they either get insurance from private insurance, they get insurance from Medicare, from Medicaid, or they're uninsured. Those are your main areas of getting private insurance, getting insurance coverage. And what happens is that private insurance pays the most. So therefore, people with areas with high private insurance tend to be areas that have lots of doctors. So here, for example, in California, there's about 57% of the people are privately insured, about 16% on Medicare, about 35% on Medi-Cal. These are the latest numbers. And then there's about 9% uninsured in California. Well, if you look at the reimbursement, private reimbursements are the highest. Medicare is next, Medi-Cal is next, and uninsured is last. So here's the payments for Medicare services, right? For private payer based upon Medicare. So you can see is that typically, it's like this is all hospital services. So private insurance pays about twice for all hospital, 80%, 90% more for hospital services, et cetera. And if you compare Medicaid, or Medi-Cal in California to Medicare, what this means that overall, Medicaid reimbursements are about 72% of what Medicare reimbursements are. And it varies from like some states, which are really low, like down here in Rhode Island, Medicaid pays about 37 cents for every dollar that Medicare pays. And then, up to some states pay higher amounts. So I just did some back of the envelope calculations. So what these differences mean is that suppose that you're a doctor and you're going to get $100 from a private patient. Based upon these numbers, you would get $70 from Medicare, you get $47 from Medi-Cal, and you get $21 on average from people with no insurance. And for a hospital, if they got $100 from a private patient, they would get about $50 from Medicare, and they'd get about $39 from Medi-Cal, and they'd get about $5 from private payers. So this explains a lot, right? Because this explains a lot about why it is that we have some areas in California where there's lots of doctors and other areas that have very few doctors, and why the area that have very few doctors tend to be areas with lots of Medi-Cal patients. And I'll give you a good example. I live up in Mariposa. Mariposa has a hospital, John C. Fremont Hospital. John C. Fremont struggles right? Because financially, because, you know, there's quite a few Medicare patients, quite, you know, a fair number of Medi-Cal patients, but they have a lot of people who just don't have insurance up in this region. You know, this is a mountain region, so they have lots of people are sort of on the edge financially. The head of the hospital used to run Mammoth Hospital. So if you've ever been to Mammoth Hospital is, you know, on the other side of the Sierras, and that they primarily, and Mammoth Hospital is beautiful. I was just in there recently, actually. Mammoth Hospital is a gorgeous hospital, really nice. So what's the difference between Mammoth Hospital and John C. Fremont Hospital? Well, Mammoth Hospital serves primarily the skiing community, and the skiing community tend to be all very, you know, upper wealthy with good private insurance. So it means that when someone gets sick in Mammoth or breaks their leg or whatever, Mammoth Hospital is primarily being reimbursed at private rates. Whereas if someone gets sick in Merced, they're getting primarily reimbursed at Medi-Cal rates. So that's why hospitals in regions like Mammoth do much better and also look much nicer and can, you know, pay doctors more and do everything else than hospitals in Merced or in John C. Fremont here. Is that clear? Is that questions about that? Now tell me, has someone talked to you about this before? You know, you're all aspiring doctors. Has anyone talked to you about this? Give me a yes or no. Well, you can see where it's going to impact you, because when you come out of, I don't know, $130,000 in debt, how much debt do you think you're going to have by the time you leave here? Anyone have a guess on how much debt you'll have? Over 300? Yeah, over 300, okay? So if you're over 300 and you're thinking, dang, how am I going to pay off $300,000 in debt? Well, you know, you could go to a place like Merced, and that Merced will actually pay off part of your debt, like the longer you stay. Or you could go to Marin County, and Marin County then has lots of doctors, but they have lots of private patients. And so therefore you're going to be able to get more reimbursement from setting up in Marin County than you'll get from setting up in Merced. And also, you know, that's only one of the factors. Also, you know, people like to live in the Bay Area, so that tends to go into the choice. People tend to end up kind of close to where their residencies are. That's usually a kind of something that happens. So there's lots of factors that kind of, you know, that kind of make it so that you know, places like the Bay Area, where there's lots of healthcare providers and there's lots of well-paid healthcare providers and there's lots of private patients, tend to just keep attracting more and more doctors. And other places like Merced, which tends to have lots of Medi-Cal patients, and not very enough doctors. So doctors, you know, kind of work here and get burned out. And then, you know, you're staying because they'll be paying off some of your medical debt, but at the same time, you know, you're also thinking about the fact that you're in an organization that's essentially getting 50% of what an organization treating the same patients, right, except for their insurance status, is going to get in the Bay Area. It makes a difference. Questions about that?
I had a question. I guess this might be a bit of an ignorant question, but I was wondering what policies or structures are in place that prevent the cherry picking of patients? Because obviously if you're getting half the pay for a certain subset of patients, I was wondering kind of like, how does that shake out in patient care in different facilities?
Well, yeah, so you know, if you think about, well, how do like in Merced County, how do patients get to Mercy Hospital? They go through their doctor, right? So, you know, in California, if I fall and break my leg, right, and I get taken down to Mercy Hospital, what Mercy Hospital is, am I Mercy Hospital's patient? Am I Mercy Hospital's patient when I fall and break my leg?
Yes.
No, actually, I'm not. Mercy, because California, you know, I am my doctor's patient. Now, my doctor might sit there and say, you know, oh, I'm going to ask Mercy Hospital's doctors to treat but my primary care doctor, I'm still their patient, right? So that's why, that's why a lot of people in hospital have to get released by their doctor. It's because if the doctor still retains control of the patient, the doctor is the one who releases the patient from the hospital. Now, in fact, what happens is that most doctors don't want to be bothered to go by the hospital. And so most primary care doctors aren't going to want to be bothered. So what they do is they basically say to the hospital doctors, you take care of my patient. I authorize you to take care of my patient. So what that means is that places like hospitals, they get their patients from doctors. Well, who are doctors going to want to, what type of patients are doctors going to want to take? They want to take private patients. In fact, when I first got here to Merced, I had to go see a doctor. And so I didn't have a primary care doctor. So I called up the local primary care doctor up here in Mariposa. And then I said, yeah, I need to come and just get a checkup. And they said, well, what's wrong? I said, well, nothing, but I just moved in the area. I need to get a checkup. I'm 50 years old, so I need to get a checkup. And they said, well, what's wrong? And I said, nothing. And I suddenly realized is that, Mariposa has 3,000 patients per one doctor. So these doctors don't do preventive medicine up here. They basically just treat people who are sick. So I called up Merced. I thought, well, Merced's a bigger place. They have more doctors. So I called up Merced. And then the first question that they asked me, so when I call up, I say, yeah, I need a doctor, can I make an appointment? What's the first question the reception asked me?
What's your insurance coverage?
What's my insurance status? That's right. And I said, oh, I have Anthem Blue Cross. And the second question they asked is that Medi-Cal? And then I said, nope, that's private insurance, through the University of California. And then they said, okay, it'll be 6 weeks. And, in 6 weeks, we're taking patients. But if I would have said Medi-Cal, then they're very likely to say, well, I'm sorry, we're not taking any more Medi-Cal patients. So, is that cream skimming? Yeah, it's cream skimming. It's cream skimming based upon insurance status. They don't have to cream skim based upon health status because, they're going to get paid mostly on the fee-for-service basis. So it doesn't matter for that. But they definitely cream skim based upon insurance status. Like take Kaiser. Kaiser, which is this great healthcare system, world-renowned. Everyone, I talk about how great Kaiser's healthcare system is. Well, Kaiser is not part of the covered California. And so why isn't Kaiser part of covered California? They could be. Well, Kaiser likes to be very selective in terms of who it is that they choose as patients. And that Kaiser likes sort of white collar, upper income type of businesses. And so they're the ones, Kaiser does, other people as well, but that's the primary one that Kaiser tends to try to focus on. And that's because there are a lot of private patients and not that many, Medi-Cal patients. So, and definitely not that many private insurance patients. So let's see a couple questions. Is the expansion of telehealth changing access in the Central Valley or rural communities? Oh, what a great question. What a timely question. The answer is yes. And it's as an exhibit, I'll show myself. As I just got COVID. I got COVID back on the 12th. And so, I was really sick after a day, so sick that I was like, uh-oh. So I did a little telehealth thing. And I went and I went on my Anthem Blue Cross and I said I wanted to do a telehealth appointment. And they, this was like 11:30 in the morning. And they said, okay, 10 minutes. 10 minutes, saw a doctor. Doctor said, what's wrong? Doctor said, well, probably need to, put you on the old Paxlovid. And so gave me a prescription and I picked it up, prescription, half hour later. So yeah, and it happened again, when I had still had COVID and I got a sinus infection. And so I had to call up again. And 10 minutes, I got my appointment. So people like me in rural areas, we definitely are going to go for virtual healthcare without a doubt. the barriers for us are not kind of, not being able to use computers or whatever it is. It's, we'll adopt it all the way through. If they could adopt it for everything, they could, if Google could come through and have a little machine where I put my finger in and they they monitor my blood and my blood pressure and everything, I'd go for it in an instant. So I think in theory, it will kind of go through and change things. I mean, will it in practice? I'm not sure, because the finances of it are still not as lucrative as the finances of having an office, having everyone come in and do your office. But Nimrat can talk more about this. Nimrat's all she's all looking into the opportunities for telehealth. So she'll be much more positive than I will. Why does Medicare reimburse so little, and do you think that will ever change? They reimburse so little primarily because it's a state-funded thing. Do I think it will ever change? No. I mean, when the Affordable Care Act came through, they went through and they upped Medi-Cal reimbursement rates, but for the most part, it's not. On the flip side, is like you could also turn around and ask, well, is it too little? Or is private too much? So, I mean, you could also ask, why does private pay so much for insurance? I mean, why doesn't private just sort of say, okay, we're going to pay whatever Medicare pays? In fact, there was a bill in the state legislature 2 years ago that basically said, okay, everyone's going to pay whatever Medicare pays. So Medi-Cal will pay that and private will pay that. And I looked at that and I thought, what a great bill. That gets rid of all this, these issues about a lot of the issues in terms of doctors not wanting to go into medically underserved areas. Gets rid of a lot of it. But, the bill failed. And who are the primary people who are against the bill? Well, private insurers, right? Because private insurers, they pay more. That means that they can get the best doctors, that they can get the best, that attract the best hospitals, all the other things. So, private could go through and pay what Medicare pays, but private likes to keep their payments more so that they get better access to doctors. Because otherwise, private, if I had Anthem Blue Cross and I couldn't find a doctor in the region, I'd be going back to my employer and saying, hey, this insurance policy sucks because, I can't get a doctor in the region. Are there any long-term stable solutions for increasing healthcare utilization by patients with Medicare, Medicaid, and those with no insurance? Yeah. I mean, this kind of, so we have 5 minutes left. So I have a whole bunch of other slides. I'll give them to you so you can look through them. But I'll answer this question. So what do I think are the long-term solutions for basically, ending this problem with too many doctors in some region, not enough in others? Well, what other countries do is that they basically regulate where doctors can go. They say, for you to set up in a region, you've got to get approval for it. That you just can't go through and set up in another region. So that's one possibility. They could do that. I think doctors would hate it. So I don't think that one will ever happen. Could they change the payment system? Yeah, they could change the payment system. They could do that type of bill. I mean, they could go for a single payer, but I don't think that that's on the cards. And I also don't think it's necessary. I mean, the problem with the single payer system is that they really went for a single payer system. And the reason why it hasn't been done so far is because, you got 57% of the people with private insurance right now. And of those 50% of the people, of that money, probably 50%, 60% comes from employers. So that means that if the government wanted to come through and to pay and to just sort of say to people, hey, from now on, you're just going to get, we're going to pay for your healthcare. It means that they would be losing all this money that right now employers pay. So they'd have to turn around and tax employers to basically get the money to pay for the healthcare system. Could they do it? Yeah, they could do it. But, will they do it in my lifetime? I don't think so. I don't think that's going to happen. I think that the more reasonable long-term solution is that you just find a different way of providing healthcare. I mean, I think that part of the problem with healthcare is that, the way that most healthcare is delivered is the same way it was delivered 100 years ago. As that you have a doctor, you have a waiting room, you have people coming in to the waiting room and sitting there, and the doctor sees a certain number of people, and that, most people have to be seen by the doctor, and then they go away, and so I think that, the way the healthcare system is kind of set up, it's still that type of model, and you just don't have enough doctors to basically run that type of model. So I think that, some of the changes that might come about with telehealth might change this, could. I think the other thing that could change it is that, they're talking about now using a lot more promotores and case managers for Medi-Cal patients. And what they're talking about doing is basically putting Medi-Cal patients into a kind of an HMO almost. And that then getting the health plans, the Medi-Cal purchasers to basically start to coordinate the care for Medi-Cal patients, rather than just paying it out to doctors. They actually get more involved with trying to coordinate care. So that's a positive thing, because that means that suddenly you've got someone who has a skin in the game to try and make it more efficient and to get people better access to healthcare, which is these Medi-Cal purchasers. So that might change things. So I think you're likely to see that come down the road more, which is the Medi-Cal purchasers and others as well, starting to do more active type of coordination of care for people. Any other questions? We have like 3 minutes left. Are there any any major entities out there right now who are working in this space that one could be involved in? Yeah, I can. I mean, you're. Yeah, one of my former PhD students now. She was the medical director at Santa Barbara Public Health, and now she's working for CenCal, which is the Medi-Cal purchaser in the region, in that sort of coastal region there. And so, she's all involved in this because, they're starting to get from the state these type of edicts that says, we want you to start to go through and to basically do this type of purchasing. So if you want to be involved at kind of that level, at sort of seeing how it's actually going to change the healthcare system, then that's probably the level to be involved in. If you want to be involved in more the ground, like the promotores level, then, I don't know. I'm not sure. Like if you just went and got a job in Kaiser, is Kaiser going to change a lot? I don't know. Kaiser already has the system they want, so I don't think they're going to change a lot. The FQHCs, well, the FQHCs are probably going to change, but FQHCs tend to change slowly because they're healthcare providers who get money based upon the number of patients they see generally, so they tend to do more relatively slowly. So I'm not quite sure how it's going to play out kind of at the local level. I don't know. Nimrod or Adriana may have a better idea, but I don't see it right now. Any other questions? All right. Well, I'll send these slides to Elizabeth, and then you can look through the other 20 slides I have. But I think that's probably it then, right?